Is about Cohen syndrome. You see, as per this Cohen syndrome, we can also be labeled as this primary aldosteronism, because Cohen syndrome is also written in this way. It's an older eponym of primary aldosteronism, and sometimes it is mistakenly written as this instead of Cohen's. A clinical picture of Cohen's or Cohen syndrome is one is hypertension, and that's often resistant. Another is hypokalemia. Hypokalemia means muscle weakness, cramps, polyuria, polydipsia. So this also leads polyuria, polydipsia. Then is metabolic alkalosis, and it's caused by excess aldosterone secretion, usually from adrenal adenoma or bilateral adrenal hyperplasia. That's Cohen's. So Cohen syndrome or primary aldosteronism encompasses these three things: hypertension, hypokalemia, or in some cases normal potassium levels, and metabolic alkalosis. So this is the manifestation, whereas it's caused by adrenal adenoma or bilateral adrenal hyperplasia. So excess production of aldosterone, that is independent of RAS, and that's independent of RAS regulation, leading to sodium retention, potassium excretion, and hypertension. So we can have, so most common cause is bilateral adrenal hyperplasia. That is the most common cause, whereas adenoma comes second. So aldosterone producing adenoma, and early we can have adrenal carcinoma or familiar hyperaldosteronism. Clinical features, as we mentioned, resistant hypertension, hypokalemia, alkalosis, and some may have normal potassium. Screening, we know aldosterone ratio is the screening test. Then we have confirmatory test, saline infusion, fludrocortisone suppression test, and this captopril challenge test. Then we have localization for adrenal, CT, MRI, and to distinguish, always remember to distinguish whether this is unilateral or bilateral condition, because CT often misses this. So you use adrenal venous sampling. So it is a gold standard investigation to distinguish between unilateral versus bilateral disease. The significance is, after you will do adrenal venous sampling, so you will confirm the disease whether it is unilateral or bilateral, because if it is unilateral, then there is potential cure. You can undergo you can perform this laparoscopic adrenalectomy. Whereas in bilateral adrenal hyperplasia, medical management with mineralocorticoid receptor antagonists, for example spironolactone, eplerenone, can be given. Note that bilateral adrenal adenomas, although they exist, but are rare. But when you will see bilateral disease, it's actually bilateral adrenal hyperplasia. That's the commonest cause of primary hyperaldosteronism. And key test is adrenal venous sampling, that guides surgery versus medical therapy. Now, why do we do washout CTs? You see, adrenal adenomas. So adenomas, they contain a lot of fat inside the cells. That is, they are lipid-rich cells, and fat makes them low density. So low density means low Hounsfield units. So HU is low on CT. If an adrenal lesion is not clearly low density, we use contrast washout protocol. So what we do is we give IV contrast, and we measure how quickly it washes out of the lesion. You see, adenomas wash out fast, but malignant tumors wash out slow. So we expect that in adenoma washout will be fast. So there will be fast washout, and in carcinoma there will be slow washout. So two methods. One is Hounsfield units. Then if you are not able to make out whether this adrenal lesion is low density or high density, when there is no clear distinction, then you go for washout protocol that we just understood. Now explaining this further, you see CT protocol, adrenal washout CT. What happens is in unenhanced this, that's non-contrast, that's NCCT, non-contrast CT of adrenals. Adenoma will have low Hounsfield units, so adenoma will have low Hounsfield units, that's less than or equal to 10 HUs. So 10 HUs. So we can also say in CT adrenal protocol, if we have a case that's adrenal adenoma, first thing on NCCT, the washout will be less than 10. Sorry, this Hounsfield units will be less than 10, and whereas the washout will be quick. Less because it contains very high fat, and in carcinoma or metastasis, you see the washout, sorry, this Hounsfield units will be higher, that is greater than 20 Hounsfield units in case of CA oblique METs. Now when we see enhanced film, that is with contrast at 60 seconds, what we say is we measure attenuation in Hounsfield units, and then we have third thing, that is delayed scan, that is 10 to 15 minutes later. So three things that we have. One is unenhanced CT, that is also called as NCCT, and adenoma will be having low Hounsfield units, that is less than 10, and NCCT of adenoma will be showing less than 10 because of fat. Washout will be quick. Second comes enhanced part, third comes delayed scan. So enhanced is done at 60 seconds, delayed is done at 10 to 15 minutes later. Now how do we calculate washout? So how to calculate washout? We have got two formulas. One is absolute washout, AW, that we calculate in percentages, and that is calculated as enhanced Hounsfield units minus delayed Hounsfield units divided by enhanced Hounsfield units minus unenhanced Hounsfield units. This is to be multiplied by with 100, and if it is greater than, this absolute washout is greater than 60%, then it is adenoma. Whereas we also calculate relative washout, and relative washout formula is same, this enhanced Hounsfield units minus delayed Hounsfield units divided by enhanced Hounsfield units, but we do not subtract unenhanced part, and that is to be multiplied with 100, and if that is greater than 40%, then it is constant with adenoma. So we have this washout, one is absolute washout, another is relative washout. So absolute washout is this, absolute washout is enhanced Hounsfield units minus delayed Hounsfield units divided by enhanced minus unenhanced Hounsfield units multiplied by 100. If it is greater than 60%, then it is adenoma. Whereas relative washout is enhanced minus delayed washout, enhanced Hounsfield units minus delayed Hounsfield units divided by enhanced Hounsfield units, and if that is more than 40%, then it's adenoma. So three things we have learned so far if we want to diagnose adenoma. One is on NCCT, it will be less than 10 HU, whereas metastasis or carcinoma, it will be having greater than 25. Second thing, washout of adenoma will be quick. Third thing, we calculated absolute washout and relative washout, and absolute washout and relative washout, it was more than 60% and it was more than 40%. If both are present, then it is adenoma. Now going further, radiological patterns. So now we will be going towards radiological patterns. So first thing is unenhanced CT, that is non-contrast CT. We know it's less than 10 HU, that means it's lipid rich, and if lipid poor, that means Hounsfield units will be greater than 10 if lipid poor. Then you have to check out. So why we are describing this, because if NCCT is already showing less than 10 Hounsfield units, then you are already certain that this is adenoma. But if there is some confusion, that is, you get on NCCT, you get Hounsfield units greater than 10, then you know it's lipid poor, but then you have to see what is the washout, absolute washout, relative washout. If absolute washout is greater than 60% or relative washout is greater than 40%, then it is adenoma. So this first criteria, NCCT less than 10 Hounsfield units, it's not mandatory. You have to confirm with washout things. And know that adenomas, they are very small, less than 4 centimeter, and they have got smooth borders, and they are homogeneous. So small, they are usually less than 4 centimeters, and they have smooth borders, and they are homogeneous. This is, you have to remember this thing. Now going further, now what is this hyperplasia? That is the most common cause. It's usually bilateral enlargement of adrenals. So glands, they look plump but maintain normal adrenal shape. And note that Hounsfield units similar to adenoma. Hounsfield units here, it's similar to adenoma if nodular hyperplasia present, but often multiple nodules are different, or this diffuse thickening rather than a solitary mass is visible. So that's why with Hounsfield units you might get confused. So Hounsfield units is similar to that of adenoma if nodular hyperplasia is present. Now we have this adrenocortical carcinoma, ACC. This ACC we have, and note that adenomas were less than 4 centimeter, but this is usually 4 to 6 centimeter, and it is irregular, this heterogeneous. It might be containing this necrosis, hemorrhagic calcifications, and Hounsfield units are already more than 20 on NCCT. That's an unenhanced film, and washout is slow. That is absolute washout less than 60%, relative washout of more less than 40%. And invasive features will be there. For example, this local extension, vascular invasion, and metastasis. Also, if patient have adrenal mets, so Hounsfield units of that on unenhanced film will be greater than 20, and washout will also be slower. That is similar to carcinoma, as we described. Absolute washout less than 60%, relative washout less than 40%. And note that adrenal mets are often bilateral, and clinical history of extraadrenal cancer also helps. So to summarize, rule of thumb is that you don't have to forget. One is on this NCCT. On NCCT, If patient have less than 10 Hounsfield units, so it means it is lipid rich and it's benign. That's adenoma. So no further workup. Now, if greater than 10 Hounsfield units, so then you have to do contrast workup. So because it can still be benign adenomatous lesion, that's why you have two things. One is absolute washout and relative washout, and if absolute is more than 60, relative is more than 40, then it is adenoma, despite having greater than 10 Hounsfield units on this NCCT film. But if it's less than 60, less than 40, absolute washout and relative washout, then it means the washout is slow. That means it's either carcinoma or it's either METS. So any adrenal lesion more than 4 centimeter, it is suspicious, and it doesn't look benign. So it is to be, or it's often surgically removed, even a benign appearing. And always combine imaging with biochemical testing to rule out pheochromocytoma, cortisol, aldosterone producing adenoma. So for example, one question is a 40-year for example female with resistant hypertension has a 2.5 centimeter adrenal mass and NCCT adrenal show 8 Hounsfield units. So what is the most likely diagnosis? So it strongly suggests lipid rich adenoma. Now let us describe this adrenal adenoma a bit. You see, most adrenal adenomas, they are non-functional. That's why they are called as incidentalomas. But some secrete hormones that determines the syndrome it causes. So if it secretes, so this if adenoma secretes, for example, aldosterone, then it's called as Conn's syndrome or primary aldosteronism. And if it secretes cortisol, then it's called as Cushing's syndrome. That's ACTH independent. If it secretes androgens or estrogen, then it lead to virilizing or feminizing syndromes. They are rare but often malignant rather than this adenomas. Now, Conn's syndrome is this: if this adenoma secretes aldosterone. Now we know how it will be presenting. And similarly, if adenoma is secreting cortisol, then it's cortisol producing adenoma causing ACTH independent Cushing's syndrome. Patient will have moon faces, central obesity, striae, osteoporosis, diabetes. And in this case, this ACTH will be suppressed. Is there any adenoma that is secreting multiple hormones? Although it's rare, but it's possible. Some adenomas can secrete both aldosterone plus cortisol. That's called Conn-Cushing overlap. This Conn-Cushing overlap. Now bilateral adrenal hyperplasia. You see, in the context of primary aldosteronism, it means bilateral hypersecretion of aldosterone, and this is the commonest cause of primary aldosteronism. That is around 60% contribution from bilateral adrenal hyperplasia. So it does not usually secrete cortisol. So cortisol not usually secreted, and it's meant to be managed with medical therapy alone, not surgery. that is spironolactone or epinephrine. So adrenal adenoma is a benign tumor. It can be functioning or non-functioning. Although non-functioning is rare, that's called incidentalomas, whereas functioning adenoma can give rise to a syndrome named after hormone it produces. If aldosterone produced, then Conn syndrome, cortisol, then Cushing's. If androgenous, then virilization syndromes. And bilateral hyperplasia leads to hormone excess depends on which cells are hyperplastic. For instance, if bilateral hyperplasia, if the cells that are hyperplastic are zona glomerulosa, then it will lead to primary aldosteronism because it gives rise to aldosterone. If zona fasciculata, you see C is more here, so that's why cortisol is secreted more. That is why it leads to Cushing's syndrome, where ACTH is very much suppressed. Now, if a 35-year-old woman with resistant hypertension have a 2 centimeter adrenal adenoma, ARR is high, renin is suppressed, what syndrome is this? So obviously it's Conn syndrome. Similarly, if a 40-year-old man with an adrenal adenoma has features of central obesity, stria, cortisol is high, ACTH is suppressed. So this is cortisol producing adenoma. And in primary aldosteronism due to bilateral adrenal hyperplasia, the hormone secreted is aldosterone. Now going to this ARR, that is plasma aldosterone concentration divided by renin. So aldosterone renin ratio. Now this renin part, it can be measured in two ways. One is plasma renin activity, that is it measures how much angiotensin 1 is generated. So it measures how much angiotensin 1 is generated, because we know renin, what it does, it converts angiotensin plasma renin, it converts this angiotensinogen into angiotensin 1. We know that angiotensinogen protein is made in the liver, so it converts it into angiotensin 1, and angiotensin 1 is then converted by this ACE in lungs into angiotensin second, and it is this angiotensin second that causes vasoconstriction, raises BP immediately, and stimulates aldosterone release from adrenal cortex, and also stimulates thirst and more water retention. So and the net result is it increases BP, it restores circulating volume, and helps maintain perfusion to vital organs. Now you see plasma renin activity. So this plasma renin activity, what it does, the renin part can be measured, that is this part, it can be measured by two ways. One is plasma renin activity, another is direct renin concentration. So plasma renin activity measures how much angiotensin 1 is generated. So it is a functional assay. So it's called a functional assay, plasma renin activity. Then we have direct renin concentration. It's an immunoassay, and it measuring renin protein directly. So renin protein directly. Now both are acceptable. Your lab will use one of them, and cutoff values differ depending on which method is used. But how is ARR interpreted? You see, high this plasma aldosterone concentration with low renin is equal to high and this aldosterone renin ratio, and this suggests there is primary aldosteronism. But if both aldosterone and renin are high, you have to think secondary hyperaldosteronism. For example, RAS, or patient is on diuretics. And if both are this leads to secondary this hyperaldosteronism. And because what diuretics will lead to decrease in volume in the blood vessels, and it will activate RAS. So both renin and finally aldosterone will be high and leading to restoration of circulating volume. Same. So whichever state gives stimulus to RAS system, that will lead to secondary hyperaldosteronism. And in both the cases, there will be high aldosterone and high renin. But if both are low, for example, patient has Cushing's, or a patient is on exogenous steroids, in that scenario we will see decreased renin, decreased aldosteronism, decreased aldosterone. So using plasma renin activity, we have to define cutoffs. So using plasma renin activity, ARR of more than 20 to 30, that in nanograms per deciliter, that is suspicious. And using DRC, ARR more than 30 to 40, depending upon units that lab has. So always remember, the absolute aldosterone level must be elevated, usually greater than 10 nanograms per deciliter or greater than 280 picomoles per liter. Otherwise, a high ARR alone is meaningless. As I said, it's meaningless if there is a high ARR alone. So absolute aldosterone level must be elevated. So I'll explain this in a while. Let's go further to see what are the mandatory requirements for positive ARR. You see, for ARR to be called positive screening test, then what you should have, this plasma aldosterone concentration, it should be elevated. It should be generally be greater than 10 nanograms per deciliter, or in other units we will say 280 picomoles per liter. So this is the standard definition. If you want to call a screening test as abnormal or positive, first thing that must be fulfilled is plasma aldosterone concentration should be more than 10 nanograms per deciliter or greater than 280 picomoles per liter. Second thing, so this was first thing. Second thing is renin should be suppressed. Renin should be suppressed. Call it primary hyperaldosteronism, and it should be very low, either plasma renin activity or direct renin concentration. And third, ratio should be high. So you need both. One is aldosterone up, renin down, and ARR high. Then only you will be telling that this has a screening test is positive. So if aldosterone, what happens sometimes is aldosterone is normal uh, and renin is extremely low. So in this case scenario also ARR will be high, renin is suppressed, but you see this one is not fulfilled here. Aldosterone is normal, so this has to be high. So this is not diagnostic. So easy examples I will give. If a patient has PAC 20 nanograms per deciliter and plasma renin activity of 0.2 and ARR of 100, you see aldosterone high, renin suppressed, so this suggests primary aldosteronism, so ARR is positive. But if PAC is, for example, 5 nanograms per deciliter, PRA is 0.2, you see ARR will be 25. Ratio looks although high, but aldosterone is not high, so it's not diagnostic. And third case is PAC is, for instance, 20 nanograms per deciliter, plasma renin activity is 5 and ARR is 4. You see aldosterone here is high, but renin is not suppressed, so likely this is, you see, plasma renin activity is also increased here, so that's why this is this looks like a secondary hyperaldosteronism. And note that this is to be tested in the morning. Patient is to be seated for 5 to 15 minutes before going for this test, and you have to correct hypokalemia first. So you have to correct hypokalemia first, that is low potassium. So this has to be corrected. Why? Because if there is hypokalemia, so hypokalemia suppresses aldosterone, so you won't get the true results. So this is to be remembered. So you have to correct hypokalemia first, because hypokalemia suppresses aldosterone production, and patient should be ideally be off from interfering drugs like spironolactone, eplerenone, amiloride, or diuretics. And ACE, ARBs, beta blocker, calcium channel blockers can affect renin and aldosterone. So these results ought to be interpreted with caution. So golden pearl, I can say positive ARR is equal to high aldosterone plus suppressed renin plus high ratio, and high ratio alone is not enough. Now there was this one question where I said this absolute aldosterone must be elevated or the ratio alone is meaningless. So you see the ARR is equal to aldosterone divided by renin. But if renin is very low, for instance from a beta blocker suppresses renin, or NSAIDs, or clonidine, or patient has CKD, or patient is old age. So these scenarios, one is beta blocker, NSAIDs, clonidine, CKD, C for clonidine, C for CKD, O for old age, beta blocker and NSAIDs. These decrease renin. So renin is decreased. So renin is decreased. So the denominator, that is this, so it shrinks and the ratio can look high even when aldosterone isn't truly elevated. That's a false positive. That's why false positive screen for primary aldosteronism becomes obvious here. So you have to have first this, you have to withhold drugs like beta blockers or NSAIDs, or if patient is on clonidine, and you have to interpret the result with caution. In a patient with CKD or patient is old age, then these results are to be interpreted with caution, because they may give false positive results. So but if a patient has a positive screening test, then that has to be followed by a confirmatory testing. But when can you even skip confirmatory testing? If the patient has the fluoride triad, that patient has spontaneous hypokalemia. So if a patient has spontaneous hypokalemia plus, patient should be fulfilling this triad: spontaneous hypokalemia, pack of more than 20 nanograms per deciliter. Third is undetectable renin. So many guidelines allow proceeding without a suppression test straight to subtyping. So you do not have to go for suppression test, that is confirmatory testing. You just have to go straight to subtyping we do with CT and adrenal venous sampling. So in nutshell, if you have to make your ARR result trustworthy, then this test preparation checklist, for example, you have to correct hypokalemia because low potassium suppress aldosterone. So what it will give false negative results, because aldosterone will be low and renin will be suppressed, so you will give false negative results. Plus liberal salt intake is to be done, and morning sample is to be taken, and the patient should be seated upright for a few minutes. Now there is one question: why liberal salt intake is to be given? Liberal salt intake, I'll come to this question in a while. And you have to you have to hold interfering drugs if safe. For example, patient should be off diuretics for almost 4 weeks, and for ARBs for almost 2 weeks. and you have to if you want to give neutral BP drugs that act as a bridge, then you can give alpha blockers like prazosin, doxazosine. You can also give Ramapil, sustained release, and hydralazine. So 3 drugs that you can still give that will not interfere with the results. One is prazosin or doxazosine, and the second is Viramapil. Third, sustained release, and third is hydralazine. That you can give their neutral BP bridge. So now why liberal salt intake is done before this part I want to clear. Why liberal salt intake is to be done before ARR testing. You see, aldosterone's job is to hold on to salt and water in the body. If you are on a low salt diet, the body what it does, it naturally tries to save salt. So what happens? Renin goes up, renin comes up, and simultaneously aldosterone goes up. So what will happen if patient was already having renin low and aldosterone was initially high? In this patient, in an ideal patient of primary hyperaldosteronism, what it does, now if patient is running on low salt diet, if patient has taken less salt for a few days, now renin will come up. Initially it was a positive screening test, but now renin will come up, so does this aldosterone. So when you will interfere this result, you will say, so this is a false negative screening test. Sorry, false positive screening test. How it will do that? You see, if you are running on a low salt diet, the body naturally tries to save salt. So renin goes up and aldosterone goes up too. So this can make a healthy person like they have primary aldosteronism. That's false positive. So you see, a low salt diet means kidney sense low volume. Kidney release renin, or aldosterone also increases. So renin high, aldosterone also high. So if you calculate ARR here, aldosterone might be modestly up, but renin is also up. So the ratio will look almost normal or low. So this can give rise to false negative result here. So this can give rise to false negative. So in this scenario, if a patient is on, so nutshell, if a patient is on low salt diet for last couple of days and you now want to do ARR to confirm primary aldosteronism, so you might miss primary hyperaldosteronism because of this reason. And now if you are on high salt diet, for example liberal diet, what will happen? The body does not need extra salt. A normal person's renin will be suppressed, so renin will become low and aldosterone will also fall, and this is the scenario. So you have to interpret the results. You see, in primary aldosteronism, aldosterone stays inappropriately high despite high salt. So a liberal salt intake unmasks the disease and makes the ARR result more reliable. Why is that? Because what will happen if you take a liberal salt intake diet? Renin will be more suppressed, but aldosterone should have become suppressed, but it doesn't. It doesn't get suppressed. So even with liberal salt intake, aldosterone remains high, and renin although gets suppressed, but aldosterone still remains higher side. So the disease becomes more obvious. So a liberal salt intake unmasks the disease or makes the ARR result more reliable in this case. Because in normal scenarios, aldosterone should also suppress, renin should also fall. But here, with liberal salt intake, aldosterone will stay high. That is what the disease is. Because in primary aldosteronism, aldosterone stays inappropriately high despite high salt intake. But here, what was happening? If you are taking low salt diet, renin will go up, and so will the aldosterone go up, and the ratio will be either normal or low. So even if the patient has true disease, you will end up missing primary aldosterone condition. So it's mandatory procedure checklist that you have to correct hypokalemia, because hypokalemia it decrease aldosterone secretion. Second is you have to give liberal salt diet to the patient. Patient should not be running on low salt diet. So in an easy way to remember is, so salt down means aldosterone up, that is physiological, and salt up means aldosterone down. Salt down means aldosterone up. Similarly, salt up means aldosterone down, and that's normal. But if it stays, if you are increasing the salt diet, but if aldosterone stays up, then primary aldosterone is present. That is the basis of confirmatory testing. When you give saline load and other things, you want to give suppression tests to confirm the disease. Now I'll discuss briefly these four confirmatory, that are four accepted confirmatory tests as per Endocrine Society and Euler ACR guidelines. I'll explain each one in simple language. One is this oral sodium loading test. Patient eats high salt diet, that is 200 millimoles sodium per day for 3 days. Okay, so you will be eating this 200 millimole sodium diet on day 1, on day 2, and on day 3. So on day 3, what you will do, you will measure 24-hour urinary aldosterone levels. You will see if it is a normal individual, obviously aldosterone will be low. So normally what you will expect is aldosterone levels to fall, that is less than 10 microgram per 24-hour will be the 24-hour urinary aldosterone level. But if it is primary aldosterone, so aldosterone stays high, that's more than 12 microgram per 24-hour. This is a simple idea. In primary aldosterone doesn't switch off despite salt overload. Now another is saline infusion test, that is SIT. Patient receives 2 liters of, so this is infusion, that's why we will be giving around 2 liters of normal saline. So 2 liters of normal saline is to be given IV over 4 hours in a patient, that too in supine position. So what is the expected response in a normal individual, and what is the expected response in a primary aldosteronism patient? So you measure plasma aldosterone after infusion. Normal aldosterone will be suppressed, that is less than 5 nanograms per deciliter, but here it remains high, greater than 10 nanograms per deciliter. So in an easy way to remember is, you flood the patient with saline. If aldosterone doesn't switch off, it's abnormal. Now third is fludrocortisone suppression test. Patient gets fludrocortisone, that is 0.1 mg q6 hourly for 4 days. You see, 4 days are there. And patient gets high salt intake and potassium supplements. Then you measure plasma aldosterone, renin, and cortisol. But normally here also normally aldosterone will be suppressed 5 nanograms per deciliter, but in primary aldosterone it remains high, greater than 6. And this is the most, fludrocortisone is the most sensitive test. And but it's for 4 days, and you have to give 0.1 milligram, that to 6 hourly for 4 days. That's why it's cumbersome test, and it needs hospital admission. And then comes this last test, that is captopril challenge test, that is CCT. You give 25 to 50 milligram captopril, that you give orally, and you measure aldosterone and renin at baseline. So you measure these two at baseline and at 2 hours. So what do you measure? One is aldosterone and one is renin. So what will happen? Normally aldosterone falls more than 30%, and if aldosterone fails to fall, it remains high, so then it's abnormal. And it is the simple, so this is simple and outpatient department friendly test, but it's less sensitive than this saline infusion test and fludrocortisone suppression test. You see, captopril, what was this captopril? Captopril is ACE inhibitor. So normally it blocks this ACE enzyme, so that's why it lowers angiotensin second, and we know angiotensin second lowers aldosterone, because you see ACE, it converts angiotensin first into angiotensin second, and the enzyme present in the lungs, and this creates aldosterone. When you give captopril 25 to 50 mg, so since captopril being an inhibitor of this enzyme, so obviously aldosterone will normally fall. But in primary aldosteronism, there is inappropriately high aldosterone concentration, and this is irrespective of the downstream pathway, that's angiotensin 1 or angiotensin first or ACE pathway. So even if this gets inhibited, this pathway, so even if this pathway gets inhibited, in primary aldosteronism, the aldosterone level will still be on the higher side. That is the basis of the test. And when I discussed this fluoride triad, I referred to the classic spontaneous diagnostic pattern where you can skip confirmatory testing because the picture is so clear that if you get PAC, primary aldosterone concentration of more than 20 nanograms per deciliter, that's equivalent to 550 picomoles per liter. And you shouldn't confuse it with another thing when I said screening test, where PAC is mandatory to be greater than 10 or greater than 290 picograms per liter. Here it was 2 nanograms per deciliter, and level in other units was greater than 290. But here it is a fluoride triad that I am discussing here. Fluoride triad, where you have to skip confirmatory testing if patient have primary aldosterone concentration more than 10 that nanograms per deciliter, but that's equivalent to 550 picomoles per liter, and patient have renin suppressed, so much suppressed that it is undetectable, and patient has hypokalemia present. So and that should not be that should be in the absence of use of diuretics, and that's called as spontaneous hypokalemia. That is, there should be no prior diuretic use. So if all three are present, it's virtually diagnostic of primary aldosteronism. You can proceed straight to subtype. If this is fulfilled, then you proceed to subtype evaluation, that I will discuss in a while. Subtype evaluation, that is with CT or adrenal venous sampling. You see, I mentioned this hypokalemia among the fluoride triad, but you know that hypokalemia is not always present. In up to 40% of primary aldosteronism patient will have normal potassium levels, and so the triad is a fast track rule, not mandatory for all patients. Now, as I discussed, we go for this that is this subtype evaluation with CT or AVS. I'll be discussing this. You see, not all primary aldosteronism is the same. There are two main subtypes that matter for treatment. One is if they have unilateral disease, and if they have bilateral disease. Patient can have unilateral adenoma, bilateral adrenal adenoma, patient can have bilateral adrenal hyperplasia, carcinoma. They can all be manifesting with primary aldosteronism. So if a patient has unilateral disease and has this aldosterone producing adenoma that we call as Conn's adenoma, then patient can be treated with surgery, that's adrenalectomy, and it can cure or improve hypertension. Even if patient, although it's less common, but even if patients have unilateral adrenal hyperplasia, although this is uncommon compared to bilateral adrenal hyperplasia, even if this is present, you can also resort for surgery. So this is the main idea here. But if a patient has bilateral adrenal hyperplasia, which is the most common, bilateral adrenal hyperplasia, so you see surgery cannot be done. You have to manage the patient medically. You give spironolactone, that's mineralocorticoid receptor antagonist, spironolactone or eplerenone. So that's why subtyping is figuring out. So what was the aim of the subtype? You figure out whether a patient has unilateral disease or bilateral. If that is also that also means whether you manage surgically or you manage medically. So what is the role of CT adrenal? First step, because I discussed here CT and AVS. So what is the role of CT? So first step in subtype workup is look for a mass. You look for a mass. So you look for a mass because that will tell you whether this is a adenoma, carcinoma or large tumor, and you rule out adrenal carcinoma because obviously adrenal carcinoma will be big. There will be local expansion, it will be having hemorrhages, calcifications, and will usually be more than 4 centimeter. So it gives a roadmap before adrenal venous sampling. But if CT cannot reliably tell you whether the nodule that seen is actually secreting aldosterone or not, because many people especially above 40 have incidental they don't secrete anything. So CT alone is not enough to decide surgery, because if you even see that there is there is this mass on CT, but you don't know whether this CT, whether this nodule that is secreting anything or not, that is secreting aldosterone or not, because it's not CT doesn't cannot reliably tell you that the aldosterone can be coming from any other site. So whether this is the that this is the bug or this is the thing that's creating the problem here, so you have to test that also, because this surgery management or medical management and finding the mass, so this all is interlinked. So you have to there is a role of adrenal venous sampling here, because it's gold standard for subtype diagnosis. So what it does, a catheter is inserted into both adrenal veins. So you have this adrenal gland here, so in both adrenal veins you insert catheter here, and blood samples taken from each adrenal veins and from a peripheral vein. So from this and from this, so you measure aldosterone and cortisol, and you compare aldosterone secretion left versus right adrenal. So here and here you compare it. Interpretation, if one adrenal is making much more aldosterone, then obviously the patient has a unilateral disease and surgery is indicated. But if both adrenals are secreting, then obviously it's bilateral adrenal hyperplasia, so medical therapy. So when to do CT versus AVS, you see, why is CT done? CT is the first investigation to be done because it rules out carcinoma, and AVS is usually required before surgery, especially if patient is greater than 35 years, because CT may show a nodule that isn't function, and CT may also miss a small adenoma. That is the reason. So two things, AVS is usually required before surgery. You cannot do surgery without AVS, because AVS is the guiding tool to see whether the patient has unilateral or bilateral, because CT sometimes miss bilateral disease. CT sometimes miss bilateral disease. That's why AVS becomes gold standard here to guide as the therapy. Because a patient can have a small adenoma and CT will miss, and CT may show a nodule that isn't functional. So if you will rely on the reports that CT is showing you, you will end up damaging the patient, because CT if shows a nodule and you do not know whether it is functioning or not, and you end up removing that, obviously you will be mistreating the patient. You will be this is your incompetence. And CT sometimes misses adenoma, which is the functional cause of primary aldosteronism. So that's why you have to do AVS, and AVS is usually required before surgery. But is there any case, is there any exception, where you can straight go for the surgery, sometimes without going for adrenal venous sampling? So answer is yes. Here I was discussing these things in age group of greater than 35 years, but the exception part is where you don't you go for surgery without doing AVS is young patients, that is less than 35 years, with classic unilateral adenoma plus florid primary aldosteronism. This is the case. Sometimes you can go straight to surgery without AVS. So simply I'll give a summary and analogy. So CT is simply a map that shows lumps, bumps, but do not function. So it does not tell us about the function. It shows some lump is here, some lump is here, some lump is here, and often it in above 35 it may miss some lumps that might be functional. But AVS is like a microphone. It tells you which adrenal is shouting aldosterone louder. So AVS is technically demanding. It is done in specialized centers, and it's also functional test. It tells which side is overproducing aldosterone, so that you can surgically remove that. You can perform unilateral adrenalectomy in that patient. If patient has bilateral adrenal hyperplasia, you do not treat that patient. You do not treat with surgery. You treat it medically with mineralocorticoid receptor antagonists like spironolactone, eplerenone. Thanks.